Hi, my name is Grainne Sheill. I'm a clinical specialist physiotherapist in cancer rehabilitation in St. James's and an adjunct assistant professor in Trinity. And today I will give a talk focused on the secondary prevention of cancer, the role of physical activity. So it's an important area, and I guess we're encouraging all of our patients to be active like during and after cancer for the quality of life benefits and so on. But we're learning more and more about the role of exercise in actually managing disease. And you can see here outcomes from a systematic review that looked at physical activity in 36 different studies, but it was nearly 70,000 patients. And what they found was there's a positive role in terms of exercise, in terms of cancer recurrence. And you can see there 21 to 35%, depending on the cancer type that you look at and the type of study, cancer mortality, and then all-cause mortality as well. So what we're trying now to grapple with is, well, what is the evidence for those different cancers, and how can we best prescribe exercise to patients after treatment with their overall health and survival in mind. This is a little bit more recent, and this looked at the broader term of physical activity. Obviously, exercise is a subset of that. And with 136 studies, they looked at physical activity across the board. So total physical activity, but that included recreational physical activity and/or leisure time, transportation, occupational and household physical activity. And what they found in this paper was that the post-diagnosis physical activity was associated with greater reductions in cancer-specific and all-cause mortality. And you can see that 30% of reduction mentioned there in some of those cancers. And traditionally, the strongest evidence has been in breast, colorectal, and prostate cancer. But this review, I guess, is starting that conversation outside of those cancer types in terms of gynae cancers, kidney cancer, stomach cancers, and lung. So when we look at specific tumor groups, then this is one of the studies, say, that would have been included in these previous reviews. And this just gives an idea of how these studies are structured. So this is taken from the Harvard Health Professionals study. This study has run for nearly 50 years and has about 50,000 people completing data entry for the study. And a subset of that population has been diagnosed with prostate cancer. So what they were able to do with those kind of 2,500 men that have a diagnosis of prostate cancer is go back and look at, well, what about physical activity? And then look forward and track over time, well, what about their physical activity after they were diagnosed? So they had a sample of about 2,500 men, and they looked at over time what happened to those who were more active. And they used kind of walking as their measure. They used, here you can see walking speed and walking duration. And they found that men that had over that 9, so the cutoff of 9 Met hours a week, they had a 33% reduction in all-cause mortality. So we're seeing this pattern here of those who are more active doing better in the longer term. And then the paper went a little bit further and said for each increasing category of total activity, it was associated with decreased risk of all-cause mortality. So the people who did more and the people who engaged in that more vigorous type, moderate to vigorous type of activity did better as well. So what they're concluding here, both kind of, you can see on the left descriptions for all-cause mortality and prostate cancer mortality, that a modest amount of vigorous activity, and they give examples of anything really that raises the heart rate, gets people a little bit breathless, biking, swimming, jogging, for more than 3 hours a week, and that can substantially improve prostate cancer specific survival. So again, we have, I suppose, a number of these observational papers now where they're following people over time and asking for self-report. And there's limitations with that data, although it's encouraging and it really sets a scene for this to be examined in more detail. It is, I suppose, reported by the patient over time. And thankfully, in recent months, so this is in July 2025, and this was presented at ASCO this year, there's the challenge trial. And this is a trial that actually enrolled patients into a randomized control trial to examine this question in a little bit more detail. In patients with colon cancer, what is the effect of this structured exercise? So again, it was building on observational studies. The study ran for a period of over 13 years with a kind of a median follow-up of 10 years. So it was a huge undertaking, and it did run in 55 centres, mainly between Canada and Australia, but that did allow them to accrue their target population of 889 participants. All patients had a resected colon cancer and who had started their adjuvant chemotherapy. So within 6 months of their surgery, they were to start chemotherapy. They were split into two groups. One was a structured exercise program, which I'll give a little bit more detail about in a minute, and one was health education materials alone. The duration of the intervention was over a 3-year period, and like that, it's relevant here as this is one of the first studies where the primary endpoint was disease-free survival. So we'll talk a little bit about the exercise program. I guess the health education materials alone was based around a physical activity and diet booklet. So the exercise intervention then again was running over different phases. In the first 6 months, the patients got 12 mandatory in-person behavioural support sessions, and they were every 2 weeks. And the type of thing that was included in this was discussions around barriers to physical activity. How could we overcome barriers, and what social supports are available to help with physical activity, time management, how patients can self-monitor their physical activity, how they can make goals. They completed decisional balance sheets, and they did a lot of work around self-reinforcement. They, with that, then completed their 12 mandatory supervised exercise sessions, and they were also advised to complete a further 12 sessions on the alternate weeks to the mandatory sessions. In phase 2, so after that initial 6 months, there was a mandatory behavioural support sessions and a supervised session only if the patient attended the behavioural support in person. And that continued then for the following 2 years, except the frequency of the intervention decreased to once a month. They gave quite detailed data on the adherence to different aspects of the program. So you can see here I've just included the kind of the mean adherence for those initial components of the exercise intervention. They do go into great detail about the further 2 years as well. The goal of the program really was to increase recreational aerobic exercise. So that's exercise where the body is moving, where patients are getting a little bit warmer, a little bit sweaty, their breathing changes. And they wanted to do that by at least 10 metabolic equivalent task hours per week for the first 6 months. And then any decision to add additional kind of med hours after that was made on a case-by-case basis. So the outcomes then for the study, the follow-up went over 10 years. So they really have, I guess, shown here a lot of detail about disease-free survival. So you can see here the curves really match for the first year, and then they start to separate. And at 5 years, the difference was 6.4 percentage points between the two groups, the exercise and the health education group. So their summary was that the exercise significantly reduced the relative risk of disease recurrence, new primary cancer, or death by 28%. They also gave information on overall survival of the two groups. And again, you can see for 4 years, the curves do not separate. However, at that point, they do. And then you can see the percentage points in the difference described later on. And their summary here was that exercise reduced the relative risk of death by 37%. So the conclusions then for this trial, which as we've said is one of the largest to look at overall survival in an exercise study, were that the benefits of exercise came from improved cancer outcomes. They did see reduced risk of recurrence in those in the exercise group. The exercise intervention resulted in meaningful improvements in cardiorespiratory fitness and physical functioning. Although that wasn't the primary outcome, they did do vigorous measures of submaximal exercise intensity in the seniors fitness test. And exercise did not reduce body weight or waist circumference, so they feel the results are independent of weight management. They have outlined that the magnitude of the benefit from the exercise intervention delivered after surgery and chemo was similar to that of many currently approved standard drug treatments. So very strong support for the role of exercise in this population following their cancer treatment. The summary is that this 3-year program was led to improvements in disease-free survival. So I guess then the question is, well, how do we start to implement this into clinical practice? And how do we ensure that patients that are on similar treatments, and about 60% of this group were on FOLFOX, how do we allow them then to access some of the benefits that the exercise is associated with? And that's what we're trying to do in clinical practice. So we have guidelines, and we have guidelines around aerobic exercise and strength exercise that really match what was prescribed in the challenge trial. So engaging in aerobic exercise to the point where you're accumulating about 150 minutes a week of that moderate intensity. And there are additional benefits for strength training, and that hasn't been described in the previous paper, but all patients are encouraged to complete strength exercise twice per week. So 2 sets of 8 to 15 reps, so 8 to 15 repetitions of each exercise is what we try to aim for. And for some patients, this is really challenging. This is very far from where they're starting from after treatment, but our main message is to avoid inactivity. So although we know the greatest benefits are associated with this level of activity, our main message for patients when we meet them often is avoid inactivity, and this is something that we kind of aspire to reach. Why is it difficult? Well, I guess when we see patients after they've had treatment, so for example, if they had had surgery and adjuvant chemo, such as the patients in the challenge trial, they may or may not present with some cancer-related impairments, and some of those are described here. So they may or may not present with cancer-related pain or cancer-related fatigue in the acute phase, but also these can be persistent and they can last in the longer term. So these can be barriers to physical activity or challenges, I guess, to the patients increasing their physical activity levels. And often it's not until we address these barriers that we can meaningfully engage patients in a physical activity program. So we I suppose have to be able to assess patients and see where they are in terms of any cancer-related impairments and address those, because we know there's substantial benefits. So the American College of Sports Medicine guidelines that I just mentioned have outlined multiple benefits, and I've just picked 3 here. 2 of them are psychological benefits of exercise. One is around anxiety, and the other is around depressive symptoms. So we know that patients who are experiencing difficulties in this area will benefit from engaging in physical activity. For both, it seems that a moderate intensity program combining aerobic and strength is best, or aerobic on its own. There doesn't appear to be a benefit of just engaging in strength exercise. And again, we start to see this concept of a dose-response relationship emerge here, where perhaps, particularly for depressive symptoms, patients who do more will experience more benefit. And then the exercise guidelines talk about supervision. So we're thinking again, if these are the symptoms patients are presenting with, and we look to the evidence, those that are offered supervised sessions tend to do better. This is in contrast to fatigue, which is probably the most common symptom that we would see as a kind of a barrier to physical activity. And I suppose that is in keeping with the literature that would show this is the most common symptom that patients will report. and it can also be quite persistent. So I guess what we're trying to understand now is, well, what's the best exercise prescription or physical activity recommendation that we can give patients with fatigue? And it appears any exercise is positive, a combination of any exercise is positive. The intensity of exercise is important, so we would encourage patients to reach that moderate intensity where they get a little bit warm, a little bit sweaty, and a little bit out of breath, rather than doing perhaps a very gentle walk at a lower intensity for a longer period. We would scale that back and work on the a higher intensity. And the efficacy or the effect of exercise appears to be independent of the level of supervision. So for a lot of these patients, we're really counseling, giving them education and advice in the context of physical activity and giving them programs that they can either work on themselves or work on with us. And in James's, when we're trying to engage more and more people in physical activity after treatment, it really is trying to do a thorough assessment on someone. So you can pick up, well, what are those impairments? What are those potential barriers to physical activity? And then we can make better decisions about the type of support that those patients need to be active. So for example, if patients present with a number of impairments that need one-to-one input, we will keep those patients with perhaps an exercise professional that they can see one-on-one. So this would be something like a peripheral neuropathy that affects patients' balance or sensory input that might put them at risk of falls when they're being physically active. Perhaps after balance re-education and sensory re-education, that patient will be much more aware of their the suitable exercises for them, and indeed they might be able to engage in physical activity or exercises that they weren't before their rehab. So that's an example of someone that we might try and keep with the goal of getting them more physically active. Others need supervision, and then they might need small group programs. And of course, our goal is really to get everybody out into the community, walking themselves, walking with friends, back doing activity or exercise that they did perhaps before their diagnosis or their treatment. And for some patients, they will need community exercise supports, and linking patients in with those can be a really nice way to ensure that there's a long-term plan in place for their physical activity and exercise. And we see in the challenge trial that the intervention was 3 years long. And of course, you're trying, when you refer to someone or when you're making a physical activity plan with someone, to ensure that it's something that has longevity, that the patients will continue in the longer term. And that's why we look at some of these options. In terms of patients who need, I suppose, rehab before engaging in physical activity, we would see this a lot with these specific impairments mentioned here. But they're not any reason. There's no reason why patients shouldn't be physically active. Indeed, there's more evidence, I suppose, in terms of the role of physical activity with some of these conditions, but they might need additional supports and information and guidance. When we do implement that kind of tiered system of like stepped care, where we're trying to connect patients with the right intervention, this is results from the Irish Cancer Society PERC study. And what we can see is that about 60% will go out to the community. But we also saw that nearly 90% of patients were very happy to receive exercise information and advice even up to 2 years after their treatment. So we see a need for this kind of counselling or this assessment and advice for patients. And then we'll see not all patients will need, I suppose, the highest level of care. We do have a lot of community options, and really this is about making the connection. And when we do connect patients to the right level of physical activity guidance and information, we can see that it has really marked benefits. So pink is before patients were connected with an exercise program, and blue is after 12 weeks when they came back to be reassessed. We saw improvements in strength, aerobic endurance, and so on. So really what we're trying to do now is highlight the body of evidence that really supports the role of exercise for people kind of living beyond cancer. But specifically, there is evidence to support the role of structured physical activity as a tool in secondary cancer prevention. And we've outlined some of the evidence for that today, mostly in the area of colon, breast, and prostate cancer, but that's constantly expanding. And some patients, in order for them to get the benefits that are described in terms of secondary prevention, will need that connection to exercise support and guidance and supportive care really around physical activity before before they will kind of engage following treatment. Thank you.